I would like to introduce Dr. Lovelace, and she's going to be talking about our aging eyes. Thank you very much.
Thank you, Maureen. And I know some of you found it. I have a little table back in the back with information on the topics we're talking about. So if you wanted pictures or a little bit more to peruse later, feel free to take those. And we'll wait on one more. I'm just going to make sure. Let's see, yes. Huh. Well, my pointer, it obviously works, but not on this screen. So I'll use my finger. We can, and if you have questions, please just ask. It's a privilege to be here with you. I'm Kim Lovelace. I work at Mercy, and this presentation is anyway several things from the National Eye Institute, and then pictures from the Academy of Ophthalmology. So just wanted to give credit where credit's due. But this is on age-related eye diseases, or the aging eye. I wanted to start with just kind of some information, and then we'll get into more disease processes in a moment. But as we age, we do notice changes in our vision. Many of them are common, and many can be corrected. And so we'll talk about things that we can do that make transitions a little bit easier and hopefully maintain vision for longer time periods. But we are at higher risk for disease processes, and so that's what we'll also be covering. This is what we normally think of as the picture we see of our eye. This is our pupil, and the colored part is our iris. We have a cornea covering it, and you can actually see those things better here. So if we turn this on the side, we have the cross section of the eye, so our eyelids and eyelashes. Our lens we're going to be talking about in a moment, because that's where the cataract forms, and then there's vitreous jelly here, and there is our retina that covers the back, and then all those nerve fibers go through the optic nerve to the brain, and it gives us the pictures that we see. This is a little more in-depth view of our retina. So there's a picture of the optic nerve. When we look in the back of the eye, what we're seeing. The macula is this area of where our central vision, and the fovea is even the very center. So 20/20 vision lives right here. And that's the problem we have with things like macular degeneration, because if this part is damaged, all of the vision that we have from out here is kind of the big E on the eye chart, what we call 2400. The eye works like a camera. We like to compare it to a camera. It's something easier for us to understand, but the eye is like the most awesome camera ever. Nothing man creates is as incredible as the human eye. So in a camera, we have our lens, the same way as the lens here. What we see is actually inverted and turned around, and our brain interprets it and puts everything right side up. It's really an amazing process, but that when light enters the eye, we say it is refracted, so it is focused. It's focused by the cornea and then also by the lens, and then it gives us this picture in the back that we can interpret as it transmits through the brain. So these are some of the problems that people notice as we age. Blurry vision, especially with reading. We need more light to see, we have more glare, we have floaters, and sometimes it's even just the eyelids and them being heavy or drooping. We recommend everyone that's 50 or older have a comprehensive dilated eye exam, and then the doctor can tell you how frequently that needs to happen. So when there's something like glaucoma, or they may recommend 4 months or 6 months, but anyway, it depends on what we find as to how often you need to come. And so what does a comprehensive dilated eye exam involve? It includes eye drops. And I'll show you what how that changes our view in a slide that's coming up. But then we use lenses and other, anyway, different equipment, something that the slit lamp, you're probably familiar with putting your head into those. It gives us a microscopic view into the eye. And those eye drops that everybody loves, I'm joking when I say that, nobody wants their eyes dilated. And we understand that. For one, the drops kind of burn. And then we don't like the feeling of the blurriness that it causes. But the reason it's important, when someone's eye is not dilated, this is the view we get. We're looking, our light can only get through a very small area of the pupil, and we can see a little bit in the back. But if we dilate your eye, we get a big view and we can see a lot. So we can look much better for things like diabetes in the back of the eyes or any other retina diseases. So that's why it's important. These are some of the diseases and conditions that we're going to look at. So we're going to look at the retina first, the cataracts, glaucoma, and kind of be moving from the back towards the front of the eye. So in the retina is that lining in the back of the eye like the film in the camera. So if your film is damaged, no matter how great you get everything else, for instance, cataract surgery, you're still not going to see as well because there's scarring in the retina. So the retina senses light, it sends images to the brain through that optic nerve. This is a picture of a normal retina. So we have our optic nerve here, it has the normal little indentation, the blood vessels all look normal, and this is that central vision, this is the macula, and then we have a little spot right in the center that's called the fovea. And that's what I was saying, the 20/20 vision, it's all right there. If we damage this area, we can't recover it. It's not something that we can rejuvenate. Just as an aside, this isn't really an aging thing, but just so that you kind of understand, you know, they tell you don't look at laser pointers, right? You're not supposed to look at the sun, like during an eclipse. There's a thing called solar retinopathy, and because it actually burns a spot right in the center. So that's the reason that you hear those things.
What's the,
Sure.
go back there. What's that bright spot on the left side?
The bright,
Well, maybe it's the light, but
are you talking?
right there, yeah.
Right
there.
here?
Yeah, what is that?
This is an indentation in the optic nerve. I'm going to try to give you a better view of that when we talk about glaucoma, because usually glaucoma is damage to the optic nerve. So everyone is born with a grade of an indentation in the nerve. Mostly in Caucasian people, it's usually about 30%. In African Americans, it's usually about 60%. So we do look for things based kind of on our understanding of what it was how the person was born and what it looked like then. If it is progressively enlarging, that's a problem. Okay.
Okay, are you looking straight in the eye there, that
Yes.
picture?
Yes.
Straight in?
Straight in. Mm-hmm.
Straight in so that the optic nerve is off to the side?
It is. Yes.
Really?
It
That's
is.
what I was getting at, I didn't quite.
Yes. Well, because the optic nerve is actually a blind spot in your vision. Have you heard that before? You can find it if you close one eye and you take your hand, and you'll find a spot where your finger disappears. So in a visual field, I'll show you in a moment. I'm going to show you a visual field. There's always a blind spot right here because this has no retina fibers, no tissue to sense the picture, to sense vision. Yeah. Good question. So, has everybody in here heard of macular degeneration? Yes, yeah. It is very common in our population. So those of us, the kind of the Northern European ancestry, we inherit it. It's part of life. My grandmother had it, and so many of my patients up here, I have that.
Is that inherited or?
It is inherited, yes. But it's not a direct, like an autosomal dominant feature. So my mom has no signs of it, but my grandmother, her mother had it. And a lot of people, they'll say, well, my sister had it, or if any of your family members have macular degeneration, I would recommend that you get your eyes checked. And we can see some of those early changes just to know if there's some mild signs of it. But
Recommend a what check? Or?
a dilated eye exam,
Oh, okay.
yeah. Okay,
It can't be stopped though, correct?
that's correct.
But it can be slowed down?
Yes,
Okay.
that is correct. Yes, we're going to be talking about that more here in a moment. I'm just going to let somebody else in. Come on in. So this is, macular degeneration is common among people who are 60 or older. It causes damage to the macula, and that's that area we were saying that's needed for your sharp, detailed central vision. This is kind of a picture of what we see in the back of the eye. We see these little white spots. These are called drusen, and they're actually little deposits. Sometimes a blood vessel will kind of grow up underneath these little deposits. and then it bleeds. And that's what we call wet macular degeneration. This is dry. You can see these little kind of black spots. That's actually the underlying pigment that's showing through. So it's an area of atrophy. So sometimes we have little bumps, and then sometimes we have these areas of atrophy. But that's what macular degeneration does. And when it damages this central area, that's when we see blank spots in our vision. This is more of a picture of kind of the wet, because there's fluid that's underneath here, and it's causing kind of a little bubble. So who is at higher risk? It's really based on age. Smoking is definitely more of a problem with macular degeneration. Our family history, we've already talked about. Obesity, and then what I already told you, it's a race. Caucasians have it. African Americans have more glaucoma. So there's things that we know to look for in different races. So this is just a kind of a picture of normal vision, and when someone has macular degeneration, they lose that central part. It's hard. My grandmother, she asked me frequently, can't you do something about this?
So does that keep growing then?
It depends on those little spots and how it spreads. So a lot of times that atrophy does kind of, we say it coalesces, so you might have a spot here, and then they get a little bigger, and it does kind of spread.
Okay.
Yeah. Oh, one other thing though. Macular degeneration doesn't make people go blind. That's a question that I frequently get, is like, am I going to be blind with this? No, because you maintain the periphery. You maintain peripheral vision. So it's still not great vision, but it's functional vision. So it's, yeah, not full blindness. So the symptoms of macular degeneration, there's really not much to tell you. There's no pain. It's the blurry central vision, and then these drusen that you can't tell are there. We have to see that on an eye exam. So our treatment options are kind of limited. They've done lots and lots of studies on macular degeneration, and thus far, the main thing that they've come up with is vitamins with antioxidants slow progression, and that's what you were talking about a while ago. When someone has wet macular degeneration, we have this medicine that we can inject into the eye that dries it up. But the damage is still there. So these are just a couple of examples. There's Preservision, or this AREDS 2. This was the name of one of the studies, and it was the latest of the studies. So I'm not saying that I'm recommending those specifically. They make generic forms, and they're the same. But this study is important. I would look for
That's a vitamin?
that. They're vitamins. Yes, you can get them anywhere, over the counter. Yeah,
So
you don't need
you
a
would take
prescription.
those before you would even get any diseases?
So if we see signs of macular degeneration, then we can recommend these. But the other thing too is you can get antioxidants from your food.
Sure.
So if you eat a really healthy diet, you don't necessarily need to bother with these things. So
Or is that mainly like zinc or?
yes, it's zinc. There's a thing called, it's zeaxanthine, beta carotene only in non-smokers. So we don't want beta carotene in someone who smokes. It increases lung cancer. But yes, it's the antioxidant.
I didn't know that.
How often are the eye injections when they have it?
They
Or
can
is
be
that
every
variable?
6 weeks. It's completely variable. So if it dries it up, then the way that they are terming it now is called treat and extend. So in the past, when they first started with the eye injections, it came out and it was like every 6 weeks people would come in and get an injection, and then it was kind of every 3 months. And they've decided that it actually dries the eye out too much if you get injections continuously. So they'll watch. They look and they see, and this, okay, if we see any signs of leakage, we have some very nice equipment that actually gives us a really nice view into the back of the eye and the layers and if there's any fluid that's there.
So every time you do that, you'd have to have your eyes dilated for you to be able to examine.
to really know that, yes. Very good questions.
Do you get that in both eyes?
Usually, yes. It can be a little bit asymmetric. So it can be worse in one eye than the other, but the drusen, those white spots, they are in both eyes.
That, once more, I know you said it, but drusen are what, those spots?
Those are the spots.
Okay.
They're like little deposits.
Yeah.
Yeah. So with macular degeneration, what can we do? We talked about the healthy diet because of eating consuming more of the antioxidants. Don't smoke, stop smoking. We want to maintain a normal blood pressure, healthy weight, exercising. This is a picture of this little Amsler grid, and I've got several of them back there. When someone develops wet macular degeneration, so with dry macular degeneration, sometimes you see little distortions in the lines, but for the most part, it's the same. If you look at it 1 week and everything's the same, and then the next week you look at it and you see a bubble, that could be fluid. And usually we're not really checking, we're not noticing it because it's small enough if you're just looking with both eyes open. But what you want to do is you stare at the little black spot, each eye separately, and just look. So, yeah. Okay. Any other questions about macular degeneration? We'll move on to diabetic eye disease. So this is a group of eye problems that is associated with people who have diabetes. So diabetic retinopathy is a leading cause of vision loss and blindness. It's very common, and the longer someone has diabetes, the more changes that we tend to see. The worse control they have, definitely the more changes we see. One other thing I just wanted to mention, it's not specifically a diabetic eye problem, but high blood pressure tends to run with diabetes, and sometimes we see blood vessels that get sort of blocked off and people lose vision along a blood vessel pathway related to their high blood pressure. So that is another vision-threatening thing that can look similar. So this is what we tend to see with diabetes. This is what we call non-proliferative, and that just has to do with the appearance of the blood vessels, really. So these are not drusen. These are they're protein exudates. So that means protein leaked out of the blood vessels. You see hemorrhages that leaked out of the blood vessels, and then it's causing swelling in the back of the eye. So just to give you kind of a little better understanding of diabetes, high blood sugars change the architecture of our blood vessels. So they become leaky. Their wall is not as strong as it needs to be, and so you get, if you think of a river, if it keeps overflowing its banks and everything's leaking out, downstream you may have a lack of blood flow, or lack of enough oxygen, really, is what the body is trying to get out of the blood. So if everything's leaking out way over here, by the time it gets to the little tiny capillaries here, then it's causing a problem. So this is all leaking out, and then the outer parts of the retina are lacking blood flow, so they start to send out signals that says, I'm dying, I need more oxygen, and those signals grow new blood vessels. Does that make sense? So now what I'm going to show you on the next picture, that's what this is showing you, is all of these funny little tiny blood vessels, and they were not there on this picture. See, these are pretty straight, and then it almost looks like a little fish net.
Mm-hmm.
Yeah. These are always bad. They actually grow into the vitreous. They break easily, they bleed, they cause a big hemorrhage in the eye, and they can end up causing a full retinal detachment. So that's why it is kind of a mandated thing, and the government is actually mandating it at this point, that everyone who has diabetes needs a dilated eye exam once a year. We don't want to get to this point.
So what do you do about it?
I'm going to show you.
Are you getting there? Okay, go ahead.
So people who are at higher risk, definitely diabetes, and the longer that you have diabetes and the more uncontrolled it is, we tend to see these changes. So with diabetic retinopathy, what you may see is splotchy vision, because it depends on where those little exudates and hemorrhages, and then the fluid and the swelling is building up, and so that's where the vision is lost. So there's not any real early warning signs, but if we can catch it early enough, there's quite a bit of things that we can do to stop that process. Main treatment, though, is some sort of intervention from the doctor. It's either a laser treatment or sometimes a retinal type surgery. They go in to the vitreous and try to remove that jelly that's in the back of the eye, where all those signals were kind of coming from. And What you can do, though, is controlling your blood sugar. So the hemoglobin A1C, that's what we check in the blood to see kind of how the levels are over a 3-month time period. Keeping our blood pressure controlled, keeping our cholesterol controlled, take your medicines, and maintaining a healthy weight, exercising, don't smoke, and then that dilated eye exam once a year. So this is an eye that's been treated. Now, obviously, it's not completely resolved because there's still some hemorrhages here. But we laser off this area in the back of the eye where those signals are originating from. And it does dry it up. So this is kind of older laser because it's pigmented in. This is what we see when it's a newer laser. Now, does this take away someone's peripheral vision a little bit? It does. It limits it. So their vision is kind of coming in because of this. But it's better than being completely blind from a retinal detachment. So, yeah. Any other questions?
What's the percentage of diabetics that get this?
I don't know exactly. I can look it up, but it's the better controlled everything is, we have been delaying all these problems. So when people who are seeing their doctor, who are taking their metformin or their medicines or their insulin, they can delay these things. It's the ones that we really have problems with is the ones that it's the blood sugars are bouncing up and up and up, and they're not doing well controlling it. And I know it's hard. I mean, it's hard to always eat the right foods, you know, and talking with the dietitian is helpful as well, because as long as when you understand that it's not just about candy and about sugar, and so cakes, cookies, and if I avoid all those things, it's carbohydrates in general, since they turn into sugars. So you're talking about your breads and your crackers and your rice and potatoes. Any of those things are also metabolized into sugar. So they make the blood sugars go up. So the dietitians kind of try to help people think more along eating a sweet potato because it takes longer to break down, or brown rice, same reason, it takes longer to break that down, and you don't get the same sugar high from those things. So diabetes is a difficult disease. Yes.
Do they find that the use of perhaps an insulin pump?
Yes. The insulin pumps are great.
That might keep the blood sugar levels a little bit more stable? Is that helpful?
Yes, it is helpful. And when they came out with Lantus insulin, that has been very helpful because it tries to control over a longer period of time. But it takes a lot of close work with your primary care doctor or your endocrinologist, whomever you see, to really get all of that as best controlled as possible. But the pumps are wonderful because they're able to manage on the ups and downs of the day that your doctor's not really there for. So. Okay. So cataracts. What a cataract is the cloudy lens in the eye that does cause loss of vision or blurring of vision. So this kind of gives you a little bit of an example. Our normal lens is nice and clear. So most children who are born have a very clear lens. Sometimes they are born with a cataract, by the way. But this happens as we age. It's a function of a lot of things. It's a function of UV rays from sunlight, from metabolism, from diabetes. If we had to take a lot of steroid doses, maybe had asthma when we were children, many things contribute to cataract formation. But ultimately what we're left with is a very cloudy lens, and it does tend to turn kind of a yellow-brown color. Every year I usually have someone come in and tell me, they have drops now that can take away cataract. Don't waste your money, okay? If you could have a drop that could dissolve this, it would dissolve a whole lot more in the eye than just this.
Yeah.
So, yeah.
You wouldn't have nearly as much work
Yeah.
either.
Well, and I'm not saying that maybe eventually they can come up with something that could delay the cataract formation, but the idea that once you're already there, you can use some drops and it's just going to magically vanish is not truthful. So, feel like it kind of it's kind of the scam type thing. It doesn't really make, I don't know. Those things bother me. I don't think anybody should be taking advantage of anybody else. But so who's at higher risk? Most cataracts are related to our aging. Everyone gets cataracts if we live long enough. So these are these other risk factors. Smoking, I didn't mention. Family history, sometimes people have autosomal dominantly inherited cataracts. Those are the kind we typically see in children. And then anybody who's had trauma to the eye, they are at higher risk for developing cataracts and glaucoma. So common misconceptions: cataract is not a film over the eye. It's not caused by straining your eye. It's not spread from one person to another. And it is not a cause of irreversible blindness. We can do something about cataracts. So the clear lens, we talked about this already. It refracts light, or it helps focus light to the back of the eye. When someone has a cloudy lens, the light doesn't get to where it needs to, and that's why people experience glare. Okay. So with cataracts, the same little picture here, our normal vision, and then when we have cataracts, it just all gets kind of blurry. This is a severe white cataract, but this is actually one of my patients in Africa. So the diseases there are quite a bit more advanced than we take care of it a little sooner here. They just don't have access.
Egg or something, wow.
Yeah, they don't have access to the same good health care that we do. So symptoms: cloudy or blurred vision. Colors don't appear as bright as they once did. Glare, and especially this poor night vision. So our treatment options: we try glasses until they just won't help anymore. We try better lighting, sometimes that helps, and then ultimately it's surgery. So things that you can think about doing beforehand: healthier diets always help with just in general our health. So wearing sunglasses, rimmed hats outdoors, and avoid smoking. Cataract surgery is recommended when the vision is not clear enough. It is an outpatient surgery. We can do it under just those eye drops at this point, and it's highly successful. This is what the lens looks like that we replace the cataract with. And everyone needs a lens. If we don't put a lens in your eye, you'd have to wear the really thick, like Coke bottle glasses that people wore in the past. So that's before we had lenses, whenever those things would appear. This is an example of the newer lenses that try to get people out of glasses. So it's kind of like having a bifocal or trifocal within that lens. So medicine continues to improve. They've come a long way. These are not perfect, but they're very good. So lots of options with cataract surgery. Any questions about that? Yes.
So when you do the actual surgery, you cut through the actual pupil and then retract the edges and pull it out?
So in Africa, that's kind of more what I do. Here, we've got really nice machines, so all that we have to do is we make 2 very small incisions on the side of the eye through that cornea, the clear part. That's the only cutting that we really have to do. The pupil is actually a hole. So when we dilate the eye, we get a nice bigger view of the cataract. So, you know what, let me go back to the one with the patient here. So I have to make 2 small incisions, kind of like right in here. The biggest one is less than 3 millimeters, and then the other one is about 1 millimeter. And then we have an ultrasound machine that works like a micro vacuum cleaner. And I can make grooves in this and break it into smaller pieces, and we just remove the whole thing. But we don't have to make a great big incision anymore.
You're removing the lens?
Removing the lens.
The entire lens?
The entire lens, because it's all cloudy. You can't leave part of it. If you leave part of it, it incites a lot of inflammation in the eye.
Okay. So that piece you had with the 2 little things hanging out, that's a new lens?
That's a new lens. All brand new little sort of plastic type lens. It's good for the rest of your life. Yes.
When I had my cataract surgery, when she was putting the new lens in, I had the most gorgeous vision of like a kaleidoscope of all colors. What causes that?
It's your retina interpreting like the light hitting the different edges of the lens, because we fold the lens up and then it unfolds in the eye, and I hear that all the time. that it's such a beautiful view.
It's like a kaleidoscope, all
Yeah.
the colors are moving.
And I had one patient that asked me if I would videotape it for her. So I can't experience what you're seeing because it's really an interpretation between the retina and the brain of those
The
lights.
white
That was
light-
just
light
during the
weight when you
surgery?
have it, huh?
Well,
It's
you're,
just during the
you're
surgery.
twilight,
Yeah.
but yeah, I
Yeah,
could
that
see it
too.
just as she was,
That
yeah,
was so pretty.
before she
Yeah.
covered it, yeah.
Yeah, many people tell me the same thing. So, yeah.
How
Okay.
old was that African patient?
Most of them around 40.
Well, they don't wear sunglasses.
They don't wear sunglasses.
that-
They're out in the sun all the time, and they have a lot more trauma. And most of their life expectancy is quite a bit less than ours. It used to be like 48 or so, and now it's actually increasing. But they never even had to think about diabetes, high blood pressure, cancer, because they never lived long enough to experience those things. So it's they are just now on the cusp of kind of having some diabetes.
Now, you put lenses, different sizes, different, what's the word for it, that can increase your vision.
Yes.
First of all, how do you determine what lens to put in there?
Yeah.
And second, can you replace those lenses?
So I'm gonna come forward here again to this. So when beforehand we take a bunch of measurements of your eye, we figure out how long the eye is, we figure out the curvature of the cornea, so that when light comes in, what lens number do we need to place there so that we can focus the light perfectly on the retina? That's what determines it. So people who are nearsighted tend to have longer eyes, so we actually need a lower number on the lens. People who are very farsighted have shorter eyes, and all of it depends on those measurements. So they've worked a long time to calculate figuring out those lenses, but it's a lot of computer calculations.
Okay, but as you age, does the size of your eye change?
Not drastically. Not enough that most people notice a difference. So by the time you've reached the point of cataract surgery, it's very minute. And the size, the actual length of the eye is not going to change. Unless there was something that, some type of trauma or something. But the length of the eye doesn't really change. So that part, the lens is good for the rest of your life. The other part, there was something else you said though that I wanted to answer. I can't remember.
Can you take it out?
That was it. We don't like to take them out because there's what we call it a capsule bag, but it's what held your old lens in place. So you think of the cataract as kind of like an M&M shape. So we put in a nice little flat lens in here. That little sack that we just set it in, and you want it there. It's like the scaffolding that's holding your new lens in place. It sort of shrink wraps over time, shrink wraps around your new lens. So can you pry shrink wrap off very easily? It's kind of difficult. So the risk of changing the lens out is high for causing a bigger problem. So can it be done? Yes. Do we like doing it? Absolutely not.
What are the percentage of your patients that end up with a secondary cataract?
Oh, they say 50%. It's high because you can't remove every little cell that's back there. And what she's talking about is behind this new lens, because we're putting it in the same place that the cataract was sitting. There's the little cells that are still there because you clean it off as much as you can, but like we said, you don't want to be too aggressive because you need it there. So one cell turns into 2, turns into 4, turns into 8, and so they replicate over time, and it causes a little cloudiness, a little film behind the new lens, and then we can take a laser in the clinic. And we just poke little holes, not in this lens, but in that film that's behind. So poke little holes in that and it falls out of the way. So the film just drops.
Because I had it after 2 years.
Yeah.
And what are the chances? Is there a chance of getting a third? Or are they very minute?
Very, very minute.
Okay.
I used to say never, until of course, one person comes in and So his wasn't on that membrane, it was actually a cloudiness that was forming on the back of his lens. But you still, with the laser, you could take it and instead of breaking little holes in, this connect the dots thing on the membrane, in that situation, if I aimed the laser at it, it would and just like disappeared. So I won't say never,
But
but
probably,
1 in 15 years.
okay.
Yeah.
Good.
Okay. Yes.
There seems to come a point where you can't get the vision corrected with glasses back to 2020. So why can't they then go in there and change that lens to where you could?
Because if it was a function of just the lens, they could correct it with glasses.
That's what?
If it was a function of the lens, then they could correct it with glasses. The problem is not the lens. It's got to be something either in the retina, like a macular degeneration, glaucoma, or just dryness on the surface. And a lot of times it's the cornea that's causing that slight blur. So, but changing out the lens is not going to gain what you're asking for.
Something else.
It's something else. Yeah. Let's go ahead and we'll look at glaucoma.
Okay.
This is a group of eye diseases that damage the optic nerve. So there's different terms that we use, but it's kind of a big lump term of glaucoma. So it can develop in one or both eyes. Primary open angle glaucoma is the most common form.
Is that the wide? She told me I have wide.
Wide angle,
Yeah,
or open
that's
angle.
what I have.
So fluid is actually produced in the eye back here in this area, and then it has to flow. It's kind of a circuitous pathway. It has to flow up here, and it flows out over in the sides there. So that's what we talk about this being an angle. And if it is closed, meaning everything's pushing forward, then that's a big problem. That's like people wind up in the ER in the middle of the night, and that's not specifically related to age, but does tend to happen more as a cataract is getting bigger and bigger. So that's an emergency that needs treatment immediately. Usually we use a laser and poke a little hole in the iris here so that there's an accessory pathway for fluid and kind of solves the problem, but sometimes vision is lost, I'm saying, or partial vision loss with that. This is trying to show you that there's increased pressure in the whole eye. The softest part of the eye is right here, so that's where the damage happens. So glaucoma tends to be high pressure in the eye, puts pressure on the nerve, causes the nerve cells to die. And that's why we see an enlarging indentation, and that's what this is showing you. So a normal optic disc, see how this one, you were talking about that lighter colored? Yeah, the lighter colored area in the nerve, this one is much bigger, it's more pale. And so you can sometimes see the blood vessels, instead of them just coming like here, you can see it coming almost straight across. Here, it's actually gone deep, and then it has to pop up over the edge because it's like an excavated deep cavern in the cupping of the optic nerve. We said this is more common in African Americans. Everybody over the age of 60 has a risk factor for it. Family history of glaucoma is very important as well. And then if there's been history of trauma to the eye, sometimes it damages that outflow pathway and makes the pressure rise easier.
What time, you talk a lot about trauma to the eye. What exactly do you mean? What kind of trauma?
A bump.
Okay.
A good hit to the eye, if you hit the eye hard enough and you dent into the lens, it causes a cataract. If you hit the eye hard enough, you damage the outflow pathway and causes glaucoma. So usually a good whack to the eye.
Airbag?
Airbags could be.
Oh,
Yeah.
really?
Yeah.
When you're talking about the pressure,
Mhm.
is that the same like when your eye doctor says your pressure, like mine was like 21 and 18 before cataract surgery, and now it's like 12?
Yeah. It does tend to drop just with cataract surgery by itself.
But that's the pressure you're talking
Yes,
about?
that's the pressure.
Okay.
The intraocular pressure. So it's unrelated to high blood pressure, but just pressure in the eye. So this same picture with those other things that we were looking at, it damaged the central vision. With glaucoma, we lose peripheral vision. So you can see it's darkening on the outside, that's why glaucoma sneaks up on people. They don't realize they have it because it's slowly coming in, And maybe one eye even completely loses vision, but they still don't really know because they haven't checked. And then when it starts to come in on the other side, then it's like, wait a minute, something is wrong. And sometimes it's too late by the time we figure it out. So the symptoms, there's no early warning signs, no pain, it's just the loss of peripheral vision. And it's very hard for a person to detect that. Treatment options, though, there's a lot. We have medications, usually eye drops that we use, and then we have laser surgery, and now combined with cataract surgery, we use a lot of little stents and they call them micro-invasive glaucoma devices. So they can help decrease the pressure. So we're trying to get away from as many drops because it's hard for people to use, you know, and especially as we age and trying to hold the bottle and squeeze it and actually get the medicine onto the eye. So lots of new things on the horizon as far as glaucoma.
Did you say
Excuse me,
stents?
when would they use lasers?
Yes. Yes,
You said
stents.
stents.
Yes.
Okay.
So
When would they
little.
use
they're very
laser?
small.
When the pressure gets way too high and the drops aren't working? Is that when they would use laser?
Sometimes we use it when someone just can't use their drops. So it can be one of the first things we try, or it can be something that we add later. Yeah. So visual fields, I just wanted to show you this. This is you put your chin in here. This is that visual field test. This is the blind spot. That's where the optic nerve comes into the eye. With glaucoma, we tend to see this field loss. Okay? The treatment depends on the specific type of glaucoma, how severe it is, and then how the glaucoma is responding to the treatment. So if the medicine you're taking is not dropping the pressure down, we need to switch. Dry eyes is I'd say 90% of my patients have dry eyes. Very, very common. Oftentimes the eye's not producing enough tears, or the tears are evaporating too quickly. Sometimes it's inflammation on the surface of the eye. And so, as opposed to those other pictures where you were seeing where things were nice and smooth, see, this is almost like gravel. You can see how the light is not hitting it smoothly. That is a very, very dry eye, and you need lots of moisture on the surface. Women tend to experience it more than men, but I have lots of men patients who have it as well. Dry eye really can occur at any age, but it does tend to get worse as we age. So the symptoms, sometimes we talk about stinging, burning, scratchy, the stringy mucus that we get around our eyes. That means that we think of three components in the tear film. We've got a watery component, we have mucus, and we have an oily component. The oil is what you need to hold the moisture on the surface. And if you're lacking some of either the oil or the water, you get a lot more mucus. So excessive eye irritation from smoke or wind, lots of tearing. So I hear my patients say, how can my eyes be dry? They tear all the time. The problem is the surface has gotten dry, and our brain and that signal anyway, if we have a smart brain, the eye sends the signal that says, help me, I'm dry. And what does our brain do? Water, 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 water. It sends the signal back and says, well, here, I'll help. It doesn't really help because it just kind of runs off. So you're really lacking usually the oil component whenever that's the problem. Dry eyes is difficult to treat though. There's not one wonderful treatment that just makes it go away. This momentary or persistent blurring when you're trying to read and you say, oh, I just get frustrated, I can't see, you're not blinking enough or your eyes are too dry. So those artificial tears that you were demonstrating are very helpful. So we've already talked about that. Oh, I went backwards, that's why. So what can cause dry eyes? Sometimes it's our eyelids, sometimes it's rubbing wrong, autoimmune diseases. There's lots of medicines that actually dry our body out, and so it decreases our tear production. Since these medicines are often necessary, you kind of have to find a way to cope with it. So treatment options, artificial tears. We don't use too many prescription eye drops except for things like Restasis, I'm sure you've heard of. There's Xiidra, there's another one that's supposed to be coming out soon. I'm not really impressed with the gel inserts, but gel tears are helpful. They're thicker. It's just some people feel like it's too gooey. So I recommend at night either a gel or an ointment And you only need a little bit. You don't want a big string of ointment across your eye, or else you're going to be blurry the next day. But it provides a very nice coating while you sleep to help keep the eye moist overnight. And then wearing glasses or sunglasses outside especially is helpful. And punctal plugs. That is, I don't recommend these whenever someone has a lot of tearing, but it's very helpful whenever the surface is just dry and they're not producing enough tears, and then we plug the drainage outflow so that you keep more tears on the surface.
I have those.
Huh?
I have those.
They can be really helpful in the right person. They make a big good difference.
Right.
So dry eye treatments or things that you can do at home, you want to try to decrease the dust load that's getting on your eye. Avoiding those dry eye conditions. So if you have dry eyes, you don't want a fan blowing in your face at night. Think about CPAP machines. You have to have the CPAP, but those are tending to shoot air right up onto your eyes. So if you have a CPAP, you need to think about using the ointment. It can really help keep your eye lubricated. Lots of eye drops. There's not one that is like the magic bullet. You have to sometimes try and experiment and figure out which one's going to be best for you. Okay. One other just quick thing, low vision. That means like when someone has macular degeneration and their vision we can't correct it better with glasses, and we're trying to figure out how can I function when my vision's not as good as I want it to be. There's a lot of things that try to help us. We call them activities of daily living. Things that can make it easier to live. And so there's low vision specialists and there's low vision clinics. And at Mercy we have one person who kind of comes in and brings in all the toys. And I'm saying toys because they're helpful things for us to use. So let me just show you. Sometimes it's just magnifiers, but sometimes there's other things that can be helpful. Little telescope glasses. On our computer screens now, we can usually turn the font up, to where it's bigger. So there's a lot of ideas that sometimes just to get us thinking of how we can make things better. Okay, floaters, real quick. Floaters are in the vitreous jelly. And a lot of times the vitreous, when we're born, it's kind of solid like a jar of jelly. After you open the jar, parts of it liquefy. That's what happens in our eye. So we get parts that are more liquid, and then it starts to fluid shift around, and it has areas that are attached to the back of the eye, and over time, those areas kind of pull away, and you'll wind up with more little condensations and things. They're just there, and they're annoying. And as long as someone still has a cataract or has a natural lens in the eye, we just kind of have to leave them alone. If you start searching on Google, you'll see sometimes we laser these. I would just be careful with it because lasering something that's back here near the retina can be a little dangerous. But we have that laser at our hospital, and so the doctors are very careful to look and see if it's something they feel like they can laser.
So they might not have that laser at Dean, I don't know.
I don't know. I know that we do have it, but whenever you're trying to aim the laser at this, you can't just make it vanish. You can try to burst it into smaller pieces, and that's kind of what the laser does, okay, to where it's not so bothersome in your vision. So most floaters are harmless. New floaters, if you see a whole dust storm of floaters, especially if you just saw some flashes of light right before it, we want you to come in and get your eye dilated, because that can be a signal of a retinal tear or an impending retinal detachment. So, okay. Eyelid problem, sorry, go ahead.
Back to the vitreous. If the volume of the vitreous itself gets cloudier, darker, oilier,
Yes.
what does that signify?
It's more of the changes in the vitreous. So sometimes we call it vitreous veils, or there's not any wonderful treatment for those things. Now the retina doctors sometimes will go in and they'll take out most of the vitreous, but it's more risky than cataract surgery, and so they're very hesitant, and they don't want to take someone who sees fairly well to go through that. But it is something that some people do have. So they'll have it's called a vitrectomy, so removing the vitreous. So one other thing just to think about, sometimes our vision is being obscured because of our eyelids. So there's a thing, it's called a blepharoplasty, where we take off this extra skin, sometimes even lifting the eyelids up. But when this is a vision problem, so it is something that medical insurance tends to cover, not just a cosmetic type of a procedure. So we are at higher risk of age-related eye diseases as we age, and we recommend you get that dilated eye exam at least once a year with diabetes, but every 1 or 2 years is good. Just to look for these other things like macular degeneration and glaucoma. So I have more information back there. What questions?
Should an average person be taking lutein and zeaxanthin?
If you don't have any risk, like as far as the thought of is there macular degeneration present, they don't recommend it. But it probably is not. It's not going to hurt anything either. So you're thinking, is it a health benefit? Antioxidants tend to be good for us in general. So just for the eye part, I can't say that we recommend it, but I don't think it's a bad idea. Okay.
And what's the incidence of a retinal detachment after vitreous detachment?
Next to 0. Yeah. Once the vitreous is pulled away, usually it's not.
Excuse me.
Oh no, please go ahead. Okay. Yeah, I guess we can go ahead and dismiss, and then if anybody has other questions, we can talk about those. And feel free to.
I have just one.
Thank you.
Thank you.